Hi everybody, myself Mrs. Lakshmi K, M.Sc Nursing, Associate Professor from ES College of Nursing, Villupuram. So today I am going to discuss one of the major complication which occurs in third stage of labor, most common one, that is postpartum hemorrhage. It is one of the most complication of third stage of labor. It is a severe bleeding and obstetric emergencies that can be a life-threatening. So what is the definition of quantitative definition? Quantitative, amount of blood loss. When it is more than 500 ml following birth of the baby, we call it as PPH. That is nothing but postpartum hemorrhage. So based on the clinical findings, we know that once the blood loss is occurred, generally, automatically there is a fall in blood pressure and raise in pulse rate. Similarly, here also, it states that any amount of bleeding from or into the genital tract following birth of the baby up to the end of the puerperium, that is the puerperial period is following the birth of the placenta till 6 weeks, we call it as puerperium. During that period, if the bleeding has occurred, that which adversely affects the general condition of the mother, evidenced by raise in pulse rate and falling in blood pressure. According to WHO, what says the average blood loss following PPH, that is normally vaginal delivery 500 ml, cesarean delivery 1000 ml, cesarean plus hysterectomy 1500 ml, minor blood loss is less than 1 liter, major blood loss is greater than 1 liter and severe is greater than 2 liter. That indicates the PPH according to WHO. Next, types of PPH. Here, major two types of primary and secondary. What is primary PPH? When the bleeding has occurred within 24 hours following the birth of the baby, that is immediately, that is primary PPH. What is secondary PPH? When the bleeding has occurred beyond 24 hours and within puerperium, as I said, 24 hours after and within 6 weeks of puerperial period, when the blood loss is occurred, then we call it as secondary PPH. It is also called delayed or late puerperal hemorrhage. So again, the primary PPH is divided into third stage hemorrhage and true PPH. What is third stage hemorrhage? That is nothing but the bleeding has occurred before the expulsion of placenta. That word is very important. Before the expulsion of placenta. The placenta is still not expelled from the uterine cavity, but the bleeding has occurred. Whereas true PPH is nothing but the bleeding occurs subsequent to expulsion of placenta. After expulsion of placenta, if the bleeding has occurred, then we call it as true PPH. Next, we move on to the causes of PPH. Here, the major highlights here are, that is first one is tone of the uterus. What is meant by tone? That is the muscle integrity, whether it is very rigid, flaccid, very relaxed. Here in the condition of PPH, the uterine muscles become atonicity. Atonicity means the muscles get relaxed. Because of relaxation, what happens? The muscle layers are relaxed. The blood vessels in the uterine cavity is also not compressed. Automatically, the bleeding is more, which leads to PPH. The majority, 80% of the cause for PPH is that is atonicity of uterus. And second one is trauma. 20% of the cause for PPH is trauma. And third one is tissue, that is any bit of placental bits inside the uterine cavity may lead to severe bleeding. And the next one is thrombus, that is blood coagulation disorders are there. That is also one of the major risk for occurring PPH. Then combined in a sense what? The mother will have relaxed uterine muscles as well as she have some traumatics in the vagina or cervix. And drugs. So as we know that tocolytic drugs are given to reduce the contraction of the mother. Uterine contraction will be reduced by using tocolytic drugs because of false pain or like that. But if it is given, automatically the muscles of the uterine muscles will be relaxed. So that leads to bleeding. So magnesium sulfate is one of the example. So let me discuss detailedly about each one causes. Atonic uterus is already I said 80% of the cause for PPH is atonicity of the uterus. Why the uterus is get relaxed? Because of some of the factors. First one is grand multipara. So as we know that grand multipara is a The mother who have 4 or 5 children, she has given birth and she is again consuming. What happens? As like our rubber band, once you stretch, it will be integrity is maintained. 2, 3, finally it gets break. The final same way here also, as the mother get pregnant, the uterine muscles become weak. So poor retraction will occur. What is retraction? No other muscles have this capability. Only the uterine muscles have the capacity to retract. What is nothing but permanent shortening of the uterine muscles. The only uterus have that ability. And second one is over distension of uterus. In which are the condition the uterus get over distended? In case of twins, polyhydramnios. And next one is malnutrition and anemia. Why malnutrition and anemia is involving in PPH? Because if already she is her HB is less than 8 gram per dl and she is malnourished, minor bleeding also will mimic dangerous to her. So we have to be very careful. And next one is antepartum hemorrhage, that is placenta previa and abruptio placenta. Next one is prolonged labor. So greater than 12 hours the mother is straining, the muscles are get weak, dehydrated, the energy all lost. So the weakness may occur in the uterine muscles, that also leads to bleeding. Next one is initiation or augmentation of delivery by oxytocin. So once you are initiation of labor by infusing oxytocin, at least 1 hour after delivery it has to be continued. Then persistent uterine distension, malformation of uterus, that is septate uterus or bicornuate uterus or unicornuate uterus, that also interfere with PPH. And uterine fibroid, after delivery of the baby, the uterine fibroid is still in the uterine cavity. What happens? The uterus get distended. So the bleeding automatically may occur. There is no contraction and retraction will not occur. Then precipitate labor. As we know that the precipitate labor is what? That is the first and second stage of labor is completed within 2 to 3 hours. So it is not a happy thing that the labor has completed earlier. It is a dangerous things which cause traumatic injury to the mother more. So we have to be very careful in precipitate labor. So as we know that the traumatic causes is 10 to 20% of the PPH is due to traumatic, especially the trauma to the genital tract, usually following operative delivery. What is operative delivery? That is venous and forceps or even after spontaneous delivery. Then here the blood coagulation disorders also cause the PPH. As I said, as we know that immediately postpartum period, the increased fibrinolytic activity will be more and it is also triggered by some conditions. What are the conditions? That is abruptio placenta, jaundice in pregnancy, thrombocytopenic purpura, severe preeclampsia, HELLP syndrome, that is in case of preeclampsia, that is hemolysis of the blood and elevated liver enzymes and low platelet count. That is a common syndrome which is occurring in preeclampsia condition. That IUD also there will be a blood coagulation disorder. So here what is the treatment we can be given means activated factor 7 may be given to control the bleeding. And other causes of PPH, yes, obesity is one of the major cause. As we become obese and the BMI is greater than 35, automatically the muscle stretching will be reduced. Then previous issue of PPH is there, age is over 40 years and use of tocolytic drugs. Already I said the magnesium sulfate, ditolrine, nefidem, which are all muscle relaxant. So once you give it will not contract the uterine muscles, automatically the bleeding vessels is not compressed and blood loss will be more. So next we move on to the prevention. Of course, every problem have a preventive aspects. Prevention is better than cure. So in the antenatal period itself, we have to identify the mother whose risk for PPH, like improvement of the health status of the woman and to keep the hemoglobin level normal greater than 10 gram per dl. That is very important because already I said if the hemoglobin is greater than 10, somehow blood loss is there, we can able to manage her vitals, all those things. But if it is less than 6 or 7, it is with mild drop of blood loss is also mimic the patient condition. So we have to be very careful in improvement of the health status of the mother, and you have to identify high risk patient. Who are all high risk patient? Yes, of course, twins, polyhydramnios, multigravida, grand multipara. Already we have seen the causes. That has to be avoided because immediately we have to screen those high risk mothers and they have to deliver only in a well equipped hospital. And third one is blood grouping should be done. Whenever the mother is coming for antenatal visit, during that period we have to do the blood grouping. As we know everyone, but it has to be done immediately to avoid wasting of time during emergency. Next one is placental localization. Whether it is important? Yes, of course. The placental localization is done in all women with the previous cesarean delivery because previous cesarean delivery is a high risk for placenta accreta or increta. That is nothing but the placenta go and attached to the serous layer of the myometrium. So it is difficult to separate. In that condition, we have to identify earlier itself. If they have such condition, it has to be delivered in a well occupied with well expert obstetrician and anesthetist. And if the woman is having a morbid adherent placenta, that means more risk for PPH. What is morbid adherent placenta? That is nothing but the placenta is attached to the myometrial wall of the uterus. You know, it is a muscle wall, so it is difficult to separate. In that condition, it has to be delivered by a senior obstetrician. So next we move on to the what is the prevention steps to be taken during intranatal period. So what is intranatal? That is at the time of labor. What are the things we have to keep in mind? That is active management of third stage of labor is very important to reduce the PPH by 60%. If suppose we are inducing the labor by oxytocin, it has to be continued at least 1 hour after delivery. And a woman is delivered by cesarean. Even though cesarean, we have to continue oxytocin 5 international units slow IV to reduce the blood loss. And spontaneous separation and delivery of the placenta should be allowed to reduce the blood loss 30%. So we should not be hurry. Once a placenta is delivered, I can complete my work. So it is not like that. We have to wait and watch policy is the main thing in delivery of the placenta. Spontaneous separation and delivery of the placenta. So next we move on to the exploration of the vaginal canal. Whenever the delivery is completed, baby is delivered and the placenta is expelled, we have to explore the uterine cavity. That is, any bits of placentas or any blood clots are there, that has to be removed. Then expert obstetric anesthetist is whenever it is always available if the mother is a high risk group. Then finally examination of the placenta and membrane. As we know that if you are examining the placenta, any cord line missing, that can be identified, any calcification infarction, that can be ruled out. So earliest missing parts can be identified. These are all the intranatal prevention. So next we move on to the management. Here immediately when the mother starts to bleed, what we have to do? First thing, we have to call for extra help. One man cannot show. So we have multiple people to take care of such condition because it is a vital area of blood loss which supplies to the vital organs. So we have to tackle immediately, otherwise it leads to death of the mother. So we have to call for extra people and immediately we have to put a canal of 14 gauge. We have to infuse a large amount of fluid, that is immediately 2 liters of NS should be administered, and blood grouping and cross matching has to be done. Keep the patient to flat and warm to reduce the blood loss and send blood for blood full count, that is RFT and LFT and coagulation profile. Why RFT, LFT has to be, coagulation has to be done? Because you know that preeclampsia, abruptio placenta, all involved this renal function test and HELP syndrome, you know, liver function test are altered. That we have to be very careful. Blood loss is there, this system is mainly affected. We have to be careful in analyzing those investigations. And we have to administer oxygen by mask, 10 to 15 liter per minute. So next we move on to the actual management. Here the 5 steps they have given. First step 1, atonic uterus, and you have to manage. And step 2, atonic uterus is not controlled, it is continuing. What is the management? Uterine massage and bimanual compression. And fourth step is uterine tamponade, that is tight intrauterine packing. And the second one is balloon tamponade. Finally, if all measures fail, we move on to the surgical methods. Let's see detail. In first one is atonic uterus, step 1. So once you identify the uterus is not contracting, immediately you have to massage the uterus to make it hard and express the clots. And methergin you have to administer 0.25 milligram IV. Then oxygen, that is injection oxytocin drip 10 units in 500 ml of NS. Then immediately you have to empty the bladder. You have to monitor the urine output. Then to examine the expelled placenta and membrane. If uterus fails to contract even after massaging the uterus, we have to move on to the next step, that is uterus to be explored under general anesthesia. Then you have to inspect the cervix, vagina and parauteral region for any bleeding, because already I done massaging the uterus. If the bleeding is not controlled, immediately I have to think if there is any trauma is there in the cervix, vagina or parauteral region. Then injection 15 methyl prostaglandin F2 alpha 250 microgram IM every 12 hours is given. Then misoprostol 1000 microgram per rectal it is given. Then uterine atonicity is due to tocolytic drugs. Already I said magnesium sulfate, etrodiol, depinephrine. These drugs cause a muscle relaxant. So muscle get relaxed. So to avoid, antidote is given, that is calcium gluconate 1 gram IV slowly. So third step is even the bleeding is not controlled. What we have to do, that is uterine massage and bimanual compression. See the picture. So the one hand is made into a fist and introduced into the uterine cavity, and the another hand is placed in the abdomen. So both hands are opposed to each other between the uterine, so that the uterine walls are opposed, the bleeding vessels are compressed and bleeding is controlled. This is a technique here, so that bleeding will be controlled. That is bimanual compression. And next we move on to the uterine tamponade, that is filling of the uterine cavity by compression. First one is tight intrauterine packing under GA. So what is tight intrauterine packing means? Or one 5 meter gauze piece with the 8 centimeter we have to take. That is to be dipped in antiseptic solution, that is fully packed in the uterine cavity. Because of the pressure, the bleeding vessels are controlled, the blood loss is controlled with the help of the tight intrauterine packing. And the next one is balloon tamponade, same mechanism. Under pressure the bleeding vessels are controlled. Here they will be using Foley's catheter or condom catheter or Saxton tube more catheters. They will be introduced into the uterine cavity through the vagina. That bulb will be inflated with 400 to 700 ml of NS. So that inflated bulb will be compressing the bleeding vessels so that blood loss is controlled. So next one is final surgical methods. If it is not controlled, we have to no other option. We have to go for the surgical method, that is ligation of uterine arteries, ligation of ovarian and uterine artery anastomosis, and ligation of anterior division of internal iliac artery, and B-lunge brace suture and hemostatic suturing. And finally angiographic atrial embolization is done. So next one, this is a B-lunge brace suture, and hemostatic suturing is a commonly used method to control the bleeding. And next, commonly it is used in PHC level and all areas it is available, that is non-pneumatic anti-shock garments. It is nothing but as you know, as we have seen in the definition itself, there is a fall in the blood pressure. So the vital organs are not receiving adequate blood supply. So the peripheral vessels are compressed. That blood will be forced to go into the vital organs, to supply into the vital organs by using this non-pneumatic anti-shock garments. You can see the picture that is available in the PHC level itself. We can use it when till the patient is shifted from the PHC to the tertiary hospitals. Thank you.